So I want to talk about some research. I'll give you some background on the Israeli system, and then I want to talk about research that I'm still in the middle of. It's work in progress in terms of analyzing data that I collected qualitatively about how different stakeholders, uh, but in this lecture it'll be mostly frontline doctors and nurses, feel about national programs in Israel for measuring the quality of care and reporting the results. Just to give you some background, Israel does quite well on health indicators, but it spends much less than the United States. Interestingly, and this is the first time I saw this number when I was preparing this talk, our expenditure is growing faster than the American expenditure. The baselines, of course, are very different. And one would ask whether the United States can afford to keep growing at all, given where it is. But still, I was surprised at the fact that our growth is higher. The out-of-pocket costs, I think, these numbers came from the Commonwealth Fund and the OECD, and I don't think they really capture the picture because in Israel we have co-payments, mostly for pharmaceuticals, and that's most of what, and then there's some private insurance for some of the population. I don't think 1,074 is a proper number for the United States for out-of-pocket spend because I don't think it really captures the meaning of having a high deductible health plan. And in Israel, we have no such thing, as I'll explain. So I think maybe this is somehow the actual average out-of-pocket spend, and it's still 1.5 to 2 times the Israeli one. But I would think that it's not really a good data point. I think the next one is very important in relation to what I'm talking about, even though I won't go into it in depth. But we have 100% of our physicians, of our primary care physicians, have had an electronic health record since the mid-90s. And America is up to 84%, but I think with a lot of glitches and problems that we ironed out long ago in Israel. Again, how people view the system, these numbers are apples and oranges. And so in Israel, 90% of people are satisfied with their health plan. In America, only 25% of people think the whole health system is working well, but I think the number that are satisfied with the insurance they have is higher. But I think overall, and again, I need to provide better numbers, I think most Israelis think that our system is basically good and working well. There may be more dissatisfaction with hospital services, whereas in the United States, a high percentage of people think the system needs to be changed. So this background is important because it relates to the infrastructure in which quality measurement programs enter. So Israel, basically since 1912, has had managed care organizations that look like Kaiser or that look like independent practice associations, but with much tighter management than the typical independent practice association in the United States. So that, and we had 95% of the public covered by 1995 in four of these health plans. I'm going to interchangeably use sick funds, health plans, and HMOs, which is important for you to pay attention to because these things have meaning. When we created these things, they were perceived to be like European sick funds. So there was a certain amount of social solidarity attached to it, and they dominated the health system along with the government. So the idea of collective and public is very entrenched in the Israeli system. And for the vast majority of Israel's history, physicians were salaried or on some kind of contract. We have a small and growing private sector, which creates some debate about inequities. But it's in my opinion anyway, it's minor compared to, even physicians who work privately, their base is in the public sector. Some people say, well, if they want to work privately, they should be totally privately. That the mix is even worse, but I don't know, that's a different paper. But there were problems with the old system that some of the funds were more like Blue Cross Blue Shield, and they had to kind of accept everybody for reasons I won't go into here. And some of the funds could be selective. So by 1995, you had some funds that had younger, wealthier, and healthier. And so in 1995, after 40 years, almost 40 years of trying, no, more than 40 years, almost 50 years of trying, the same year that the United States started trying in 1948. And I, at the time, in 1993, I was here on sabbatical in New York, and I thought, who's going to make it first, Clinton or Israel? And I wasn't sure, and in the end, it was Israel. And one can argue whether the United States has gotten to NHI, which obviously stands for National Health Insurance, but it felt like waiting so long, I called it New Heavenly Intervention. And we'll see what kind of new intervention you're going to have here with the ACA. So what we have should sound familiar to anyone who knows the idea of managed competition, which in Europe is called regulated competition. And we have 4 HMOs. Every citizen has to enroll in one of them. And because they are the ones that are qualified to provide the standard basket of services that's defined and guaranteed with sufficient finance in our national health insurance law. So that's based on a health tax that we pay that's progressive up to a point. And the government's, if the health tax is not enough to pay for the standard basket of services, then the government kicks in general revenue. It's of course a political football every year, but basically nothing can be in the basket that doesn't have coverage financially. So an insurer can't say to you, I'm not giving you that service that's in the basket because I don't have enough money, or for any other reason. And this is, John, this is what I was referring to. We have this standard basket since 1995, and to add to it or to take away from it requires the approval of the Minister of Health and the Minister of Finance. Most of what's happened since 1998 is adding to it, but you can't add anything unless it has a price tag on it. So about 1.5% to 2% increment is added every year for new technologies, which of course doesn't mean that means we only can fund a small percentage of the new technologies that want to get into the basket. We can only pay for a small amount of them. The HMOs receive a risk-adjusted capitation, which is supposed to be enough to pay to cover the services for their population that are in the basic basket, and they can offer supplemental insurance for items that are not in the basket. Skipping over a lot of wrinkles and problems that there are in this system, because I don't have time to go into them, but to get to where the quality measurement programs meet this structure, because in 1995 they didn't exist. So first of all, we have very entrenched health information technology systems. Citizens and providers are familiar with narrow networks. We have a modicum of what's called social solidarity in the Israeli system. And we have this fairly well-developed system of managed competition. And there's a recognition that there are limits, even in healthcare. So the public seems to understand, and this is a different data that I have, a different lecture, but the public seems to understand that not everything can be covered. And the distance between professionalism and managerialism in the Israeli system, because of the 100-year tradition of physicians working under some kind of managed care operation in which many of the physicians become the managers, it doesn't mean that there aren't problems. And you'll see some of the problems in my data, but compared to the United States, at least as I understand it, the gap in orientation, professional orientation between physicians in the field and managers is greater here than it is in Israel. And all of what I said is, as you'll see in the data, is more true of community situations than the hospitals, because the hospitals didn't run that way.
I guess the question is the 2 slides, the 10% who weren't happy, or however many slides.
Yeah.
Are those disproportionately people who were born in the US or Europe?
I've wanted to do that research for a long time. And what I can tell you is it is definitely not disproportionately the Arab population, even though they suffer gaps in health and inequities. They were a large part of the 5% that weren't insured before. So, you know, where you're coming from makes a difference. But that's an excellent question, and I've wanted to study it for a long time. Okay, so I'm going to start with the quality indicators in community health. It began in the early 2000s as a voluntary collaboration among the 4 HMOs together with Ben Gurion University. And they would meet and they would discuss the literature and they would sort of share with each other their thoughts. But there was a trust element based on this because officially they're in competition. So, you know, there was a kind of a gentleman's understanding that you don't, this is amongst us, okay? It's good for whoever knows to know that all of us are involved in this effort to discuss quality indicators, to think about where we need to improve. In 2004, it was the Ministry of Health put its umbrella over it, and the National Institute for Health Policy, which was created as part of our national health insurance law to evaluate the implementation of the law, got money from the Ministry of Health to run this program as a national program. And a directorate was, yeah.
Just so there's no public reporting.
Okay, so if you look down in 2010, once it became a higher profile program by the Ministry of Health, and it was being run by the National Institute for Health Policy, and it's run out of a shop like this one in my university, right the door next to me, which is a directorate that meets with stakeholders to develop the measures, collects all the data, and reports. And the reporting is a result of the Israeli ACLU demanding that this information has to be open. I was kind of worried that it would kill things, but it didn't, because I don't think, if you look at the reports, it's very hard for the average citizen to read how his health fund functioned on 49 different measures and decide whether that means he should move to another fund. And so I think overall, it's good, but in the data that I'm going to show, there's going to be some relating to the issue of publication. Yeah.
Is the funding given to each of the HMOs similar per beneficiary, or how do you?
You mean the capitation payment?
Yeah.
It's, yeah.
Also, is there, people can switch equally back and forth, there's no residency?
No, you can, they're national funds. Israel's small. The reason people switch is usually not due so much to the quality of care as there could be inertia, and there could be, if you move from Jerusalem to Tel Aviv, a lot of people will switch from one fund to the other because one is stronger in Jerusalem historically and one is stronger in Tel Aviv. Only 1% move every year. So you can say, what kind of competition is that? First of all, I hope it was clear, there's no competition over price. There's no premium competition over the basic basket. So the competition can only be over service and quality. And so you could say, well, if only 1% is moving, then how is it competition? And maybe it's not competition, but it's what in Europe would be called contestability. The fact that you may be, the net movement may only be 1% doesn't mean that you want to lose. You want to be the one that loses. And you could see the four funds competing. They want to keep the people that they have. It could also be that some groups are weaker in the market and are less likely to move, but I don't think that's kind of a basis for inequity. Not the budgeting of the funds or what fund you're in. There are other reasons for inequity, but that's a different lecture. So this program is population-based. This program gets all the information on the indicators from all of the health plans. And they go and they check, they do quality control to see that the reporting is being done properly. And we get national level rates, but we also get the report that comes out compares the health plans on the performance. I'm just going to, there's 49 measures right now in these areas of health. And in the next impressive slides that are out of date, they're from 2012, and I borrowed them from someone who worked for the directorate, and I'm embarrassed that I didn't do updating, but I think the situation's only gotten better. So you can see that over the time that the quality measurement program has been in existence, BMI documentation has gone up significantly. Colon cancer screening has gone up. Cholesterol control and the amount of people taking statins and the target has gone up. This is just Israel in comparative perspective. So colon cancer screening is a tough one for everybody, but Israel's kind of right up there. Influenza vaccination for people over 65 going up. This is one that's interesting, not so much for the specific indicator. First of all, it's interesting that there is an indicator like this. Influenza vaccination for people who have diabetes. I don't even know the implications of that. But what's interesting is to see that the leader is Scotland. And in a very crude way, Scotland, of all the 4 countries that's there, is the most single-payer system of these 4. Okay, so that's just kind of what that says is we have this quality indicator program. On a national level, it's led to improvements. I didn't show the comparative data, but the comparative data shifts depending on what indicator you're choosing. So now moving over to the hospital, which started much later. It started in 2010. It was not a voluntary coalition of hospitals. Not that each hospital wasn't doing quality measurement on its own and trying to do improvements of various kinds, like hand washing and infection control and errors. But there was no national program. And I think the Ministry of Health that's responsible for the hospitals, seeing this great community program, said, we have to have a program like that for the hospitals also, but it came top down. It wasn't, so the hospitals kind of much more feel that this has been imposed on them, much more than the health plans do. And you have these areas, yeah.
So just one other question of clarification. So if I'm understanding it correctly, the health plans manage all of the reimbursement for outpatient care, and the Ministry of Health manages all the reimbursement for the hospital care?
No, it's an excellent question. The health plans are financially responsible for hospitalization. Outpatient clinics, which in some cases you have to get a referral or an approval from your HMO, either to even have the consultation, but more likely where you're going to have the consultation, because the HMOs do have selective arrangements with different hospitals. And there's a tussle in Israel over freedom of choice to choose the hospital you want and going according to the directives of the hospitals. And I think probably on the margins, some people who, I don't think people move because they don't have freedom of choice, but they will express themselves, and that will pressure the fund. But the HMOs, and this, in my opinion, is a flaw in the Israeli system, they don't do any management of the hospital care because under the reimbursement arrangements, they're paying a capped budget to the hospitals. So the hospitals have a budget in advance, and Israeli financial accountability is not what it is here. You know, almost no hospital is going to go bankrupt because at the end of the year it has a big deficit. It's going to go with its hand out to the government, and the government will make either give them subsidy and go like this, or they'll shift the burden around, and they'll say, well, if the hospitals are in deficit, then the HMOs have to pay more, and their cap will go up. Then the HMOs will complain, and they'll say, we need more in the capitation. And that's how Israel kind of handles the financial limits, by, first of all, setting them, but then kind of moving. And it creates some chaos. It's not healthy to have a deficit-run system. But citizens don't really feel the deficit in terms of access to care, except for sometimes there's overcrowding in the hospitals. But I think that's also because we have so few beds per population. We have the lowest in the Western world in acute. We have less than 2 beds per 1,000. So that's, you know, it's not so much the reimbursement, it's the development to add more beds. Yeah.
So I'm just trying to picture some of this and pick up a little bit on Naomi's question. So if I'm a hospital, do I likely have contracts with all 4
Yes.
of the plans?
Yes.
And so is there any motivation whatsoever for a plan to actually know the quality of the hospital and to make selective contracts? They can't actually benefit from doing that, right?
I think they could. I think they could.
I mean, in theory they could.
No, if they advertise, if they said, we make our choice of hospital based on quality. But that, I think, is a real flaw in the system, that there's this separation between community and hospital, and that the health plans are not really managing or being held accountable. They just pay.
They're just a pass-through of money.
Yeah, yeah. Well, they do. No, they do say you have to go to this hospital, but it's based much more on the financial contract than it is on quality of care.
So they could make a financial contract tied to quality measures if they were.
Well,
so
I
inclined.
think they could. I think they could. That's not what I would want to see. What I would want to see is that they channel their patients. They make their financial contract, but they also tell their patients, part of the reason we chose this hospital to work with is their quality, not to reward them with volume, not with
They're using a
fees.
Centers of Excellence designation is the other way of doing it, rather than doing
Yeah. Israel has a lot of arguments about centers of excellence because everyone thinks they're excellent. Okay, so that's a tough one. And in a small on the one hand, in a small country, the Ministry of Health says, look, you can be helicoptered in or driven, from a peripheral area to Jerusalem, Tel Aviv, or Haifa pretty quickly. Why are you demanding to have, the center of excellence? But the hospital has, people, it's a small country. All the doctors know each other. There's a lot of competition for prestige. And so that's a tough one, centers of excellence. So these are the indicators for the hospital. So for instance, within that, for myocardial infarction, getting an EKG from the ambulance before the patient arrives at the emergency room, giving aspirin to acute coronary patients before they're hospitalized, performing a balloon angioplasty within 90 minutes of a suspected myocardial infarction and recommending aspirin at discharge after the ACI. And these were determined mostly by the Ministry of Health. They do consult with the various physician groups and the hospitals. Do they accept these measures? But I think it's fair to say that the pressure is more top-down than in the community program. And so this is an example. You see the progress in Israel of the percutaneous intervention within 90 minutes, but there's variation among the hospitals, and this is published data. I don't know that I would base my decision living in Jerusalem on where I would go based on these data, but the data is available to the public, and the idea is to get everybody, and this isn't over time, this is a snapshot of 2015, so there's probably also for each hospital an improvement in this. And this is where we stand on that indicator compared to some other countries. Big improvement over time, but we're still less than the UK and the United States. So, given all of this, my question was, how do various stakeholders, especially frontline staff, feel about these programs of measurement? And the reason it's interesting, and I'm going to go fast here because I want to get to the data, is that these programs have unintended consequences, and just showing that there are improvements doesn't show some of those unintended consequences, because you could be improving in an indicator and not improving in something that isn't being measured, and that can be a problem. Also, the measures, even though in Israel these measures are not attached to any financial incentives for anybody, but there still can be a pressure on the intrinsic incentive to be a good doctor or a good nurse, and the pressure to meet the measure, which is extrinsic to you. And that we can pay a price for that. Then there's the question of, is this kind of measurement at all, to what extent is it appropriate for physicians? So this is a great issue of health services research from last year. Hal Luft has a nice article in it. And basically this was the intro to it, saying, physicians are more like federal judges than they are like apple pickers, which means we cannot just count numbers. We just can't quantify their quality the same way. On the other hand, we can't let them, if a judge takes a long time to do a case, it's probably not the same as a doctor, not seeing more patients because he's taking too much time or doing too many tests or whatever. But it's, the argument is they're probably more like federal judges than apple pickers. And then this is the slide I made this morning after thinking about these issues and having presented it to different people, and I've been doing a lot of reading on this subject during this sabbatical. And so one that I heard from Henry Mintzberg at McGill, and I admit that this morning when I started writing it, I said evidence versus experience. And then I said, everyone's going to raise their hand and say, well, it doesn't have to be either or. So I changed it to and. But the things that are all on the left-hand side, the beginnings of the sentence, are the ones that I feel are getting the emphasis in our field. And the things on the right-hand side are like residual. And my argument is we may get out of balance. We may already be out of balance. So evidence and experience, technical measuring, and the social context in which the measures are carried out. Jerry Groupman's How Doctors Think, I don't know how many of you have read that, but Jerry Groupman is basically saying, a doctor can't be too hasty. He's got to recognize his own biases, and he has to really scan his thinking and what he knows and ask for other opinions before he rushes to a decision. Jerry Groupman would say, quality measures do not correct for the biases, okay? I sat with someone at the National Council for Quality Assurance, and I mentioned Jerry Groupman's name, and the response was, not a fan, okay? You're just letting the doctors do whatever they want. And they have to be measured, okay? Professionalism and managerialism, okay? The medicine as a profession, nursing as a profession versus being part of a big organization and working according to guidelines and being measured. Silver bullets and comparative institutional analysis. We tend in our field, for whatever reasons, I think because we need to defend our business, we sell silver bullets. We say that measuring the quality of care is going to improve the quality, and it's going to save money, and it's going to tell us what's value in healthcare, as opposed to there are a lot of different ways you could mix the left and the right in different kinds of institutional arrangements. And data and measurement will certainly be part of it. But what part of it, we haven't really established yet. And whether it has to be the same proportion that's based on evidence in every hospital, or could you say, look, that hospital, we know they have the data, but we're not even going to look at what they do with the data because we trust them to use the data in some way that will, because we look at the way their institution is built, and we say the data, the measures are going to find a good place, but it's not necessarily the same place as the hospital right next door. Maybe the hospital right next door really needs a much more technical approach. Data as an endpoint and data as a language. If data as an endpoint is you either hit the measure or you didn't, and we report it to you, end of story. Data as a language is we get the data on our performance and we use it it's part of our culture. It's part of our cultural language in our organization. And the one that I added right here at this table, value and virtue. So the trend now, whether it's a continuation of the ACA or whether it's something new under the Republicans, value as a goal is going to assert itself. Value-based purchasing of healthcare, paying professionals for value. It's true that Tom Price is against all that kind of stuff, but I think it's going to insinuate itself no matter what. And the question is, if this makes its way down to the front line and physicians and nurses say, we're getting paid to produce value as defined by someone else, but does that fit with what makes us a virtuous professional or not? And finally, and here I could be wrong, but I don't think I am. I've looked quite a bit. I heard comments from previous talks. I don't feel that except for this article in the Israel Journal of Health Policy Research, which you all should look into and contribute to, quickest path to an impact factor probably in journal history within 2 years had an impact factor. And it's really a nice little journal, and they turn the stuff over fast, so that's a little bit of marketing. I'm not on the editorial board, but I serve as a kind of unofficial associate editor all the time because my friends run it. And this article was published back in, I think, 2013, and basically what it shows is that Israeli physicians, so this is their perceptions of the quality indicators in the community program. And if someone has similar research like this from the United States, I'd like to hear about it. I've been looking for it, but I haven't found it. When I was at NCQA, I said, do you do any research on how physicians and nurses in the HMO, in the organizations that you're reporting about, how they feel about this? And they said, beyond anecdotal, no. And we should, but we don't.
Can you clarify, these are views of ratings of physicians or ratings of plans? Ratings
Primary care physicians responding to questions about the measures. I don't know if it's readable, so
But measures of what?
The quiche measures that I showed before, the 49 community measures. No research like this has been done in the hospitals. My qualitative research is the first one. So,
But
yeah.
it's measures of their health plan performance. It's not individual, none of the individual.
No, it's
physicians
not,
know
it's their, this chart is their reaction to the measurement program.
But the feedback they get, it doesn't have to do with their
That's what we're trying to get at,
performance.
right?
No, it can.
They can get
It-
individual level
They
performance?
can, yeah, yeah.
Interesting. Is
yeah.
that publicly reported to people?
No.
Oh.
No, the health plan data is publicly reported.
Mhm.
So they're saying, hey, it's fine if you rate health plans, is what you're saying?
Yeah, and they're also saying that it contributes, 66% say it contributes to trying, can you read it? Trying to improve. And the clinical areas selected were appropriate. Okay, that's even higher. Okay, 80% say that the measures are good measures. The indicators were defined appropriately. That's a bit less. And the indicators need to be modified. About a third feel that, there should be work to modify the indicators. So that's the only research I found on how frontline staff feel about these kind of programs. So I wanted to understand the perspectives qualitatively down at different levels, and especially physicians and nurses, and I wanted to see if the quality in the community is different from the hospital. We did in-depth, semi-structured interviews and focus groups. We tried to get representation of the different sectors, and we did the usual transcription and analysis of text, not with a computer. We're doing it manually, reading and bringing out categories, and I admit there's still work to be done. 36 interviews and 14 focus groups, so there's quite a bit of data. So just some findings. So what we got out of our data so far are these kind of major categories, and this is for the nurses, how they feel about it. And what came out were general perceptions of quality, measurement and professional quality, factors that encourage a quality climate, factors that hamper a quality climate, the hierarchical and environmental contingencies in which the program is being carried out, and how do they feel about publication of the data. So in the subcategories, there's a sense among the nurses that quality has become something that they're talking about all the time in their work, that it's built into the work plan in the hospital, and it gives a feeling, the measurement and the discussions about quality give a feeling that people are paying attention. Measurement and professional quality. Measurement is part of the work process. There is not always a connection between measurement and quality. Measures are not identical to quality of care and patient experience. Measurement is humiliating. And measurement can destroy the balance between professional behavior and focusing on the measures. Subcategories under factors that help. It's not dependent on resources. It's more a question of people getting on board. Leadership is important. If the leadership in the hospital is constantly emphasizing the quality issues, that's something that contributes. Discussions among the staff about the measures ingrain the measures into the hospital behavior, the behavior. I'm not separating here between community nurses and hospital nurses. These are categories of all the nurses. Got to do more work to separate out the two. Having built-in forums to discuss the quality measures, using the measures for professional development, that's something that's interesting. The nurses are basically saying, we want to raise our professional status. And being involved in the quality measurement program is something that leads to our professional development. If there are specific people that are responsible for pushing and managing the program, and in contradiction to the first one, it's not dependent on having resources, but it would help if we had more resources to enter the data, especially for entering the data. That's the biggest burden. Things that hamper an environment are the multiplicity of measures, the bureaucracy and the time devoted to filling out forms, the negative impact that there can be on the atmosphere in the health delivery organization, and damage to the patient care or relationship. If you're busy entering numbers and you're spending less time with the patient, that can hurt the relationship. In the hierarchical environment, accreditation programs are more rigorous than the quality indicator programs. So I went out to study the national programs, but what I didn't know is that at the same time I was doing this research, the International Joint Commission for Hospital Accreditation was selling its wares in Israel, and a lot of the hospitals were going through that process. And so that process ended up being in competition with national indicators. And that's an interesting observation. There's a sense that the Ministry of Health kind of supervises all of this from afar, but that it's disparate and distant from the internal organizational environment. But the middle management mediates between the Ministry of Health and the frontline staff. The selection of measures is appropriate to the organization. There are efforts to make them appropriate. They come down from the Ministry of Health, but then there's discussions, can we push back a little bit and say, our patient population is different. Can we have a little more flex on this measure? But that process is taking place mostly in the community care and less in the hospitals. And again, taking into account the contingencies of each institution and applying the measures. Regarding publication, they say the published indicators do not reflect our work. And there has to be tolerance for errors. Okay, if there's measurement of the number of times that errors were made in treatment, there has to be some tolerance for that. I'm sure many of you are familiar with what goes on in Britain with the star ratings. And in Britain, when there's errors, heads roll and hospitals are closed. Internal publication is good. They don't mind sharing their individual performance with their colleagues and peers. The doctors, I won't have time to go through the same chart for the doctors, only the quotes, but just to give you a flavor of the kind of quotations that were behind those categories. So in the conception of quality, quality has become part of regular terminology that we all use. I dream quality, okay? I personally believe very much in quality measurement, but it's not something that's yes or no. It has to be part of a much larger and broader process, and it's ongoing and cyclical. The dialogue about quality inside the hospital, the department director and the head nurse, it's been ingrained. Appointing quality leaders because they thought that if it is a concept that everybody sees differently, there should be some common concepts among those leading the hospital. So there's an effort to try to get a common mental model of what the quality measures mean for the hospital. Factors that impede, okay? It has become the end and not the mean to get to something. And that's the problem in my view. I think it's become like the Chase for the Million TV show in Israel where people have to do a treasure hunt and find and they get $1 million if they succeed. It has also been installed in a very inflexible framework, also very limited, and one that signals almost apathy to the significance of the measures. That is to say that we have made them into the goal. The overall goal has become almost negligible in the measures. But what is behind this? Very often nothing. And interestingly, this is from a nurse in the community. You hear that much more from the nurses in the hospital. Okay, I'm just going to skip over to the doctors, and I won't go through the chart. But as long as I get to this one, I think this is the This is the one that has raised the most eyebrows when I've given this talk. The doctors say quality indicators are very salient for the nursing staff. It's usually led by a group of nurses, okay? So the physicians see this as something that the nurses should be doing more than they should be doing. The main investment should be in choosing the indicator, because you can choose measures that do not really reflect your activity in the product. And this is my star quote for the physicians, and after this one I'll skip to my conclusions. Factors that impede a climate of quality. We have to fill in the box for thrombosis, otherwise you can't finish the admission, but the item is irrelevant. In other words, someone comes into the emergency room, you have to check whether they're having a thrombosis, whether you as a physician think that there's a chance that that's happening or not. That's in the quality indicators of the Ministry of Health. You have to check it off. In other words, there's a perception that on one hand you are a physician and you will do your work responsibly. On the other hand, you will fill in the form like a little boy. The quality measures and the things they are stubborn with us about, that at a certain point is an insult to our intelligence. That's my position, that these things have transformed from decision aids to decisions made. It's supposed to support our judgment, not replace it, and in many cases it comes off as replacing it. Okay, so this is that tension that I was talking about in my. So what do I come away with so far? That you want to use these measures, but you don't want to introduce too much competitive pressure. So right now, the staff, especially in the community, but even in the hospitals, are willing to discuss comparative outcomes with others, but they don't want it to spill over into becoming too competitive, and they have a fear that it could. The information systems have to be in place. You have to deal with the administrative burden on the medical staff to enter the data, and that's in a system that has one medical record for all the 4 health plans. In the United States, a physician or a nurse that's entering the data and a hospital that's reporting could be entering it for 9 or 10 different payers, which makes it incredibly burdensome. There is a danger of starting to practice to the measure and not according to what you feel is right as a medical professional. Responsibility versus authority. Within the hospitals and within the health plans, there are variations in the way the quality measures are used, and the effort to improve quality is carried out. But the national programs push towards standardization. How will this tension work out in the future? I think that it's going better in the HMOs than in the hospitals, and that the nurses are more involved. We're almost finished. I don't know if it matters. Yeah. The nurses have a different role in this than physicians. So these are obviously sort of not only my tentative, they're more than being my tentative conclusions, they're directions for further research. And since I don't want to do the research, they're for you. So if that helps you stake out a route for where you want to go from here, I'm glad. I'm going to settle with, I have thousands of pages of text that I still need to analyze and refine and report on, and you've only seen tip of the iceberg. So thanks for listening, and I don't know if we still have time for questions or discussion. Anybody, any comments, any? Thank you very much.